Welcome back to Core de Roy, the heart of clinical care. I'm your host, Dr. Roy Ziegelstein. We've got a fantastic episode lined up, including a conversation with Dr. David Hellmann, an unbelievable innovator and educator in medicine. David and I will discuss innovation in medicine, the evolution of medical education, and something near and dear to us both, patient trust. We also have a number of segments where we'll delve deeper into recently published research, discuss technological advancements, and other things that I think you'll find interesting. So, without further ado, let's jump in. Today, we'll be starting off by diving into the latest peer-reviewed studies and major reports in our segment, Recapping the Research, to explore their clinical implications. And I actually wanted to do something a little bit different here. It turns out that in mid-April, the British Medical Journal's publishing group retracted nearly an entire guest-edited special edition of the Journal of Medical Genetics. Interestingly, that special edition was published in 2019 and was dedicated to cancer immunotherapy. Now, let's just pause for a minute and think about that. The journal made this decision because of, quote, an irreparably compromised review process and, quote, improbable device use. But those articles that were rejected were in the public domain, potentially to influence medical practice for 7 years. And it turns out that journal articles often contain inaccuracies, and when attempts are made to reproduce results, even of published landmark trials, it's not uncommon for contradictory findings and less strong effects to be found in these subsequent trials. A recent report, in fact, published in the Journal of the American Medical Association found that while the Food and Drug Administration, or FDA, describes clinical uncertainties related to trial design, conduct, analysis, or reporting, the documents in which they report those uncertainties are generally not read by clinicians who typically rely on journal publications for information about the drugs. This is actually really important. And so you might say, why is someone like me who's focusing on AI clinical decision support even talking about this topic? Well, it turns out that when you're using clinical decision support tools, and AI clinical decision support tools in particular, you really need to look for products that have their content reviewed and graded by experts, content experts, expert clinicians, and experts in evidence-based medicine and evidence grading. Be wary of clinical decision support that assumes that the vetting has already been done by the journals they partner with. Because when the clinical decision support tool assumes this, so do you as a clinician, and by extension, so do your patients. Now, I will admit that assumption may be right much of the time, but in healthcare, being right much of the time is not the standard you should accept or tolerate. I could go on, but we have a lot of ground to cover, so let's get into the next segment. However, if you think I missed something, let me know on LinkedIn at Roy Ziegelstein. That's Ziegelstein. We're back with another Tech Talk, where we'll discuss innovations impacting clinical workflows. You may have seen a recent article that explores how ambient AI scribes are driving higher healthcare costs. Largely, it's thought, through increased coding intensity, more complete documentation, and higher patient volumes. Now, I'll admit, it may be possible that ambient AI scribes have this effect. However, unlike some other technology solutions that have made their way into the exam room, I believe the primary purpose of AI scribes is to make it easier for clinicians to care for patients, not primarily for billing and coding. The truth is, it's cheaper for the system when sick patients go without care or with suboptimal care. When sick patients can't be seen, or when clinicians only have time to attend to a single health problem for a patient that has multiple medical issues, it's cheaper, at least in the short run. And in the short run, it's more expensive when patients get care and when they get good care in particular. Again, in the short run. So if ambient AI scribes increase clinician efficiency, I'm not surprised that in the short run, care seems more expensive. But in the long run, it will be cheaper and better. So I don't agree with the conclusion that ambient AI scribes increase healthcare costs. I believe that if more patients are receiving better care in the long run, it will be better for the public and cheaper. And cheaper and better is a great combination. And if you can improve clinician well-being at the same time, well, then you've really hit the jackpot. AI may be changing how patients and providers access information, but it's not replacing care. More to come about the importance of the human element in care delivery in my conversation with David. Last episode, I introduced a new segment, Personal Perspective, where I share examples from my own clinical practice. With today's theme of medical education, I thought I'd take a slightly different approach and lean in on my experience as an educator and also my experience as a cardiologist. There's been a lot of buzz in the media about nutrition in general, and of course about nutrition in medical education. I feel really comfortable speaking about medical education as someone who's been involved in that field for many years. And I feel comfortable also speaking about nutrition in health and health education because I'm a general cardiologist who spends much of my time counseling patients about healthy eating, and personally, because I have a daughter who's a registered dietitian and, of course, an amazing one at that. I want to start with a more general comment, though. Medical education and medical care has had too much of a focus on fixing problems rather than preventing them. And the truth is, you need both. And it's better and cheaper to prevent illness than to treat it once it's developed. And many illnesses, not all, but many, are preventable. You know, I learned almost nothing about diet and nutrition in medical school, except as nutrition related to specific diseases. I think nutrition education in medical school should follow what's called reverse engineering. Start with what you want the finished product to be and work backward to develop a curriculum that's most likely to yield that finished product. So in the case of nutrition education, the public wants common sense, actionable nutrition information that takes into consideration their unique health situation and also their financial situation, what's available in their neighborhood or community, and so forth. Making a recommendation about diet to someone who has to travel miles for fresh fruits and vegetables, or who can't afford some healthy foods, or doesn't even have a working refrigerator or stove, is altogether different from making a recommendation to someone with access, and there's nothing that will lose your patient's trust more quickly than hearing a recommendation from a clinician that makes no sense for you as a person. It makes the person feel that the clinician is out of touch and doesn't know who they are. I'm continuously learning in my everyday, and I hope this example encourages you not only to learn something new, but also educate others on what inspires you. And now, my interview with Dr. David Hellmann. It's really a complete and utter pleasure for me to be interviewing David Hellmann today. Hands down, David Hellmann is a role model to more people in medicine than anyone I know for sure, and likely than anyone, period. He is the consummate clinician and medical educator. He is a rheumatologist. He was the co-founder of the Johns Hopkins Vasculitis Center, and he was the co-founder and directs the Johns Hopkins Center for Innovative Medicine. And I want to stress that word innovative because we're going to touch on that a little bit later on. The Johns Hopkins Center for Innovative Medicine that David leads promotes patient-centered care. Remember that too, patient-centered care, because we're going to also touch on that through the creative collaboration of research, teaching, and patient care. David, welcome here. We're going to talk about three things today. We're going to talk about medicine as a public trust. We're going to talk about knowing the patient as a person. And we're going to talk about technology and how technology affects those first two items. David, maybe you can first start by just giving a little background, because many listeners may not know who you are, and maybe how your background connects with your interest in knowing the patient as a person.
Right. Thanks so much for having me and for demonstrating yet again one of your most appealing characteristics, your overgenerosity in describing me. It's great to have a chance to be with you and your audience. I originally from Kentucky, then went to Yale, and then to Hopkins for medical school and residency, and to UCSF for rheumatology training, and then back to Hopkins for the last 40 years. And I've been at both of the Hopkins campuses, and I've served as chair of the Department of Medicine at Johns Hopkins Bayview until 2020, and was also vice dean for the Bayview campus to 2020.
Thanks, David, for giving a little bit of background. How does that background contribute to your interest in knowing the patient as a person, which you've dedicated so much of your career to?
I think it begins with my father. My father was a general practitioner in Louisville, Kentucky, the first in his family to go to college, or for that matter, medical school on the GI Bill after serving in the Air Force in World War II. And as a solo practitioner, he was very busy and was working 7 days a week. And so my four siblings and I, if we wanted to spend much time with Dad, we joined him on house calls. And so for as long as I can remember, age 4 or 5 years old, going on house calls with my dad. And for the most part, we stayed in the car and tried not to fight too much. But occasionally we were invited inside. And although I was only 5 years old and could dimly perceive what was going on, I had the sense that something important was going on between my father and his patients. And I think that was the first inkling that I got that medicine was really, really special.
You know, you and I both know that a lot of patients, when surveyed, say that their doctor doesn't know them as a person. Why do you think it's important for doctors, clinicians in general, to know their patient as a person?
I think sometimes making mistakes can be the best teacher. And I remember an epiphany that I had when I was an intern at Johns Hopkins Hospital. And I was assigned to taking care of an 11-year-old boy who needed a bone marrow transplant. Now, I was training in internal medicine, and so you could ask, what's an internist doing taking care of an 11-year-old boy? But in those days at Hopkins, the pediatric patients were taken care of by internists. He was very sick and had failed 2 rounds of chemotherapy. And there were very few centers doing this, what was considered then a last-ditch effort in 1977, a bone marrow transplant. And he had just wonderful parents and a loving sister. Unfortunately, in those days, there were not yet ports. And so every time he needed blood drawn, I had to draw his blood from a percutaneous stick. So almost with Pavlovian conditioning, he began to associate seeing my face with pain. And yet he had a very complicated disease and complicated treatment, and I wanted to make sure that everything got done. But I was completely out of my depth. And at the end of the month, unfortunately, he, despite the bone marrow transplant, was dying. And I, at the end of the month, was to be transferred to another service, as was the habit. And I puzzled over whether or not to tell him goodbye. My residents had taught me never disappear on a patient. I thought, if I go in to say goodbye, he's just going to see my face and he's going to think I'm there to draw his blood and he'll start crying. But with more faith in the residents who taught me than in myself, I knocked on the door, quickly said, "I'm not here to draw your blood." And I then talked to him about how I recognized his suffering as a human being. I recognized the pictures on the wall showing him with his soccer team and related how horrible it must be to be nauseated, to have no hair and not being playing with your playmates. I'm not sure, Roy, exactly all the things that I said, but I remember feeling that my heart poured out to him. I stopped and he didn't move and didn't say anything for what seemed like a long time, but I suspect was only a few seconds. And then one of his favorite things in life was detailing and painting in great detail these model cars. And he reached over and picked up what I knew was his favorite car, a yellow Mustang. He picked it up and turned to me and handed it to me without saying a word. It took me probably 10 years before I could tell that story without sobbing in recognition of that an 11-year-old boy was capable of such act of generosity. But that experience taught me the value of the quote attributed to Osler, that the good doctor treats the disease. The great doctor aspires to treat the patient, the person with the disease. And I realized, although I had done what I thought was a good job up until that time, checking every box, making sure he had every test done, every medicine delivered, what I realized I hadn't done is recognized his humanity, recognize who he was as a person. And finally, at the end of the month, I did that, and that made a profound difference for him to be recognized as a suffering human being, and certainly changed my life. It is that memory of Joey that has propelled my career to focus on knowing each patient as a person.
David, that is such a beautiful story. I mean, it is very moving to think about it even now, many, many years later. I don't know if you still have the yellow Mustang, but I will say that the gift that Joey gave you is one that has, as they say, kept on giving, because you've given so much to your patients and to all the people that you've taught. And if Joey's story is behind it all, just think of his contribution to patients and physicians of the future. So thank you for sharing that story with us.
Well, thank you. And I wish that, unfortunately, he did die shortly after he gave me this gift. But I do think of him often and wish that there were some way to thank him.
I think he must feel thanked. I want to switch over to what I think is a related topic. Everybody who knows you, David, knows your mantra, medicine is a public trust. There is literally not a person who has interacted with you who doesn't hear that in their mind echoing in your voice. What does that mean to you?
No, thanks, Roy. It shows if you repeat yourself enough. My grandfather was fond of saying, repetitio est mater studiorum. Repetition is the mother of learning. And so perhaps I picked up that habit of repeating something. To me, it means that medicine is a covenant with patients and with society. And that covenant is that physicians are supposed to focus all of their efforts on improving the health of their patient, their family, and communities. And that in return, society has given physicians tremendous gifts, relative autonomy, respect, relatively high pay. I think that's the theoretical construct. But for me, it's much more than a theory. I simply am in awe of all of our predecessors, many of whom you know as well, both at Hopkins and in institutions throughout the country and world. And I feel that medicine is a jewel, and that so many people before us in medicine have come with their jeweler's cloth and burnished this gem. And I believe that it's the joyful opportunity and obligation of each physician to both admire that jewel and to hold it up and be able to recognize that there's still some rough undersurfaces. And that's okay, because that means there's something for you to do, there's something for me to do, there's something for everyone in the audience to do. And I believe that all of us should be getting out our own jeweler's cloth to try to add luster to this jewel so that the next generation will find it just as sparkly, just as attractive, so that they can add to it. That's what I mean by medicine as a public trust. It's a gem.
Thanks, David. You know, I think to go back to knowing the patient as a person, I think we would probably agree that there are many values added by knowing the patient as a person. Related to the trust issue, do you think that knowing the patient as a person contributes to a patient's trust in their physician?
Absolutely. And I'm glad you brought me back to this, because I've talked about my personal experience, but as you know, there's an abundant literature indicating that patients do better, have better outcomes when they feel their doctor or nurse knows them as a person. So there are profound benefits for patients in every setting that has been studied. I'm struck that being known as a person is the soul of healing for many patients. And I believe that for many physicians, it's also the soul of rejuvenation. I kid that I've never worked. And I also ask people, don't tell the dean that, because I still like getting paid. But I don't feel I've ever had to work for pay. It is the joy of knowing my patients as people that really keeps me going.
And David, how do you think in today's, pressured environment, how do you think time pressure in particular affects doctors' ability to know their patient as a person, and related to that, the trust that patients have in their doctor?
I think it affects it a lot. But I do believe that it is possible to imbue physicians with the importance of knowing their patients as people, and that they can develop techniques in which, if they learn them well, even in relatively modest periods of times, they can end up knowing about their patients as people.
So this is sort of a segue to the last item that I said we would talk about, which is technology. One of the things that I think some people don't know about you is that you are what I would consider to be a technophile. I think that a lot of people would believe that someone like you, who is a medical humanist and teaches the importance of knowing the patient as a person, that you might be a technophobe. And certainly anyone who watched you put on your earphones and plug in your mic for this podcast would definitely think that you're a technophobe. But I know you as a technophile. More than 20 years ago, you embraced the use of what is now called POCUS, or point of care ultrasound. More than 20 years ago, when a lot of people didn't even know what it was. So my question for you is, technology, whether you define that as the stethoscope, the point of care ultrasound, artificial intelligence scribe, however you define it, how does that affect the ability for clinicians to know their patients as people? Do you see technology as an enabler? Do you see technology as a foe? Talk about that.
Technology is a tool, and every tool can be used wisely or unwisely. And I think that my embrace of certain technologies all flows, I hope, logically from a focus on medicine as a public trust, and that our job is to do the right thing for patients that helps them. It's not about my beliefs of what should a physical exam consist of. What patients want is they want us to get it right. They want us to get it fast. They want it to have us do it in the most effective way possible. And I long ago embraced bedside ultrasound because there's very good evidence that even in Osler's hands, there's some parts of the physical exam that are difficult and do not give reliable results, such as left ventricular function. Really tough to estimate that always well from just the physical exam. Volume status can be very difficult to judge, particularly as many people have gained weight and so forth. But ultrasound allows you to do that really, really well. So instead of insisting on using techniques that have proven limits, I embrace technologies to make that better. Artificial intelligence and scribes, I think, offer a great opportunity to spend more time listening to the patient, looking at the patient, and less time writing notes. So I think the technology, if always used from the perspective of, does this improve things for the patient, that we'll get the right answer as to how to use it.
Thanks, David. Last question. Not everybody is as fortunate as I am to have the opportunity to spend a lot of time with you. And I would imagine by this point in the podcast, people are jealous of me. So my question for you is, what questions have I not asked you? What would you like to say that maybe my questions didn't prompt?
Shay, that's a really good question. I think given that I am superannuated, that I've been around for a long time, I think one question would be whether I remain optimistic about the future of medicine. And I am absolutely wildly enthusiastic about the future of medicine. I have often thought in my career that when people talk about the good old days, they're largely old, and that I see all sorts of promise for the present and for the future. As you know, our profession is attracting the best and the brightest. And studies have shown, and our experience is, that this attracts people for the right reasons. They want to make the lives of their patients better. They want to further discoveries that will improve health. And I believe that medical educators such as yourself are doing a lot of things to try to make sure that the experience in medicine not only retains those reasons that people went into medicine, but embellishes them. So, yes, there are lots of challenges, but we're going to get through them just fine, particularly if people keep remembering one thing: medicine is a public trust.
I knew you'd end there, David, and I'll just say you may be, by your estimation, superannuated. By my estimation, you're just plain super. I want to thank you seriously for joining me and sharing your insights on ways to bring clinicians back to what matters most, the person sitting in front of them and the public trust. Thank you, David.
Roy, thank you so much. Love being with you.
That's all we have for today's episode. I want to thank you again for joining me, and a special note of appreciation to my guest and friend, David. Please stay tuned for more episodes, which will be released the first Tuesday of every month. Like and subscribe to be notified of new episodes, and please connect with me on LinkedIn. I'd love to hear your feedback. And if you liked this episode, remember, this is our third episode in the series. There are 2 others that are also fantastic, and I really hope that you do tune in, not only in the future, but even tune into our older episodes. I think you'll enjoy them. Until next time, stay true to the core.